Facebook Live, and you've opened the broadcast. Thanks a lot, Peter, for the ICT support. We will be starting shortly. Welcome to the attendees. We are live and we are looking forward to a very nice learning session. I'm your host tonight. I'm Dr. Joy Mugambi, a family physician from Baringo County and Nakuru Division Chair, and as well leading the program of physician mental health webinars. With me is my team, Dr. Yvonne Orlando. We have our president, Dr. Wera, is in the house. We have our vice president, Dr. Tara. Dr. Kigondu has logged in. Thank you very much for being here always. Edith, who's also part of the mental health wellness webinars, who's very active in also ensuring that there is smooth flow. Edith Koba from Eldoret. We also have Dr. Catherine Gitao, who is also part of the mental health and wellness for health workers and is a psychiatrist in Nairobi, who's the CPD coordinator, Kenya Psychiatric Association. So this is a partnership between Kenya Medical Association, Kenya Psychiatric Association, the Nursing National Nurses Association of Kenya, and the Clinical Officers Association of Kenya. We also have KMPDU on board, and our partners who have been part of us, the Equity Fund and EGF, have been very supportive all through. We note attendees are logging in. We will be starting off in a few, and we are on Facebook Live. So if you're on Facebook Live, you can put down your questions on your end. Those on Zoom, please ensure you're with us for at least 30 minutes so that you do get your CPD. And those on Facebook Live, ensure you have logged in, and we will also ensure that we have monitored and dispersed CPD accordingly. So tonight we have Dr. Kigamwa, who's with us. I'll be speaking more about his portfolio. He's a renowned psychiatrist. And on your end as attendees, you will note the panel looks this way. 1 minute. Your panel as attendees on your end looks this way. Please do click on the link if you want to chat, and it's not a question. If it's a comment, a compliment, do drop it on the chat. If it's the chat looks this way, you can chat to everyone, or if you have an individual query or a chat, you can ensure you click down, a drop-down panel will come here, and you can find the panelists that you would want to converse with. On the other end, there is the Q&A section. The Q&A section is where you drop in your questions that you would want our speaker or our panelists to answer you. The Q&A section looks this way. You can either input your question with your name. We will acknowledge your question and you as a person, or if you want to drop down an anonymous question, do click send anonymously and we will respond to that. We've been having the division rounds, which had been on hold for a while, but we hope to come back in over this week and start off with the division that started off, which is Nakuru division, and then move back to the other divisions to hear where they are at now. We've had their experiences tackling COVID all through, but we want to hear where things are at since the gates of Nairobi were opened and how things are within those divisions. So without further ado, we are now on our 14th series of the mental health webinars. More resources are within our KMA resources, and we'll be sharing more about the presentations that will be held throughout the week. We have our Thursday clinical case management webinars, and then Friday division rounds. So I'll welcome our president, Dr. Were, to give us his opening remarks. Welcome, Dr. Were.
Thank you, Joy. Good evening, everyone. Thank you for joining this mental health webinar, which is a series of webinars on mental health, which Dr. Joy has actually taken us through with our other partners. And we hope that as Dr. Kigamwa takes us through, then we'll be able to have a very good discussion as we discuss the eating disorders. So thank you so much for joining this KMA webinar, and we appreciate all other partners and the support that we've been getting from Joy and Professor Tuoli and his team. And we hope that now that you've started, that we'll continue the same cycle that we used to have. Thank you, and enjoy the webinar.
Thank you, Dr. Were. I would like to post an apology from Professor Were. Professor Tuoli. He may not be available tonight, but a large representation of KPA is here, and they will support him in terms of the panel procedures. So today I would like to welcome Dr. Kigamwa. He's been in practice for the past 18 years. He's a holder of MBCHB and M.Med in Psychiatry of Nairobi, of the University of Nairobi, and a certificate in clinical psychiatry from the University of Orange, Free State. He has previously worked in Machakos District Hospital when there were districts, and Embu Provincial Hospital, and also served as a secretary of the Kenya Psychiatric Association. We welcome you, Dr. Kigamwa. We look forward to hearing more about eating disorders. With all this stress of COVID, food sometimes is very comforting, and it's actually the most abused addictive substance. So welcome, Dr. Kigamwa. You're free to upload your presentation.
Hello, good evening again. Sorry, can you hear me?
Yes, we can.
You can, okay. So I'm very glad to be able to talk about this group of disorders. And I thank you for the honor of inviting me to do so. How I find myself talking about this eating disorders is a bit baffling to me, but I remember Dr. Gitao sending out an invite to people and asking, what topics that I thought, well, maybe I can try this particular one. Now, having gone through it, I realize in DSM-5, they are what they are calling feeding disorders and eating disorders. So I chose to focus on the eating disorders. The other feeding disorders are pica and rumination disorder. So there will be 3 disorders that we shall look at. Probably the first 2 are the main ones, and then the last one we shall touch on as we conclude. I know the time is a bit limited. Traditionally, eating disorders have not really been an issue for us in developing countries, in Kenya. I remember as a young doctor, actually I was a student, a medical student, coming across the very first case of anorexia nervosa, which happened to be in a medical doctor, or medical doctor admitted at Kenyatta Hospital, who eventually succumbed to it. And I was to stay many, many years before I met another case of anorexia nervosa, but not in an African. This time it was in an Asian, a young Asian girl. But eating disorders are actually probably more common than we really than they really get reported. What I found is that whenever we are dealing with the patients who are a little obese, who have depression, and you casually ask, they very often are embarrassed to even talk about, especially bulimia. But anorexia nervosa, not common, but I do see maybe far much more number of patients who have bulimia. Anyway, it's an eating disorder. It's characterized by a disturbed body image where an individual is looking at their bodies and thinking either they are too big, too fat, or the shapes of different parts of the body do not seem to fit a particular desired shape or fit. They then may embark on a path of self-induced starvation, which can take various forms, and we shall look at that in a short while. There is a morbid fear of being looked at as being fat, either subjectively, that the individual thinks they are fat, or they are actually fat and people notice them to be fat. But most times it will be, especially in anorexia nervosa, a totally almost delusional level of thinking. There is also associated serious malnutrition because they have a very disordered relationship with food and therefore overlook the nutritional value of foods. And then to say also that these disorders have actually significant mortality. Now, according to DSM-5, the diagnostic criteria for anorexia nervosa states that there is a restriction of energy intake relative to requirements, leading to significantly low body weight in the context of age and sex. And that would be the restrictive type, where the person makes every attempt to ensure that they are not converting food into fat and therefore weight gain. And so they do restrict. An intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain. And that would be things like, excessive amounts of exercise, use of medications like laxatives and diuretics to try and restrict. And then, of course, the purging, the inducing of vomiting to try and not get that food to be absorbed into their system. And then there's this psychological thing, this mental thing, a disturbance in the way in which one's body weight or shape is experienced. That a person looking at a person with an eating disorder will think to themselves, okay, maybe you do look fine or you're a little underweight, but these individuals will constantly look at themselves as being, they have a body dysmorphia. They fear that their bodies are large and in excess of what they should be. So their evaluation is distorted. It's a distorted perception of their bodies and the way they look. They also have a persistent lack of recognition of the seriousness of the current low body weight, because the low body weight means nutritionally these individuals are compromised, and are prone to other complications related to nutritional deficiency. The DSM requires us to specify if we are dealing with anorexia nervosa, is it a restricting type where the person does not take in food, basically starves themselves, and may even sometimes purge, but it's restrictive, they exercise, they do their medications, and then there's the purging type where they will induce, they will eat, binge, and then they will induce vomiting. And according to the definition, the restricting type, during the last 3 months, the person has not engaged in recurrent episodes of eating or purging behavior. And the binge eating type, in the last 3 months, that the person has engaged in recurrent episodes of binge eating or purging behavior. And then they have a criteria for impartial or full remission, that a person has remained, has some of the symptoms or has absolutely no symptoms. And so they're either in remission or partially in remission. And then they have a criteria for severity, where they look at the BMI, the body mass index, and they say if your BMI is above or equal to 17 kilograms per meter squared. In other words, they would take your weight in kilograms, divide it by your height in meters squared. So if it's above 17, they would say then it's a mild form. It's between, if it's between 16 and 17, it's moderate, and 15 to 16 severe, and less than 15 is looked at as being extreme or very, very severe. And then there'll be associated features, nutritional features, where the person will have deficiencies, will have things like reduced bone density, will have features of malnutrition. They may also have associated features of depression, sadness, loss of interest, suicidality, features of obsessive compulsive disorder, where they obsess about food, they become collectors of recipes, they hoard food, and they are very, very particular in the way they do things. They are also may have concerns about eating in public. They don't want to be seen. They are also concerned about how effective they are in their daily lives. They tend to be very inflexible, very obsessive in the way they do things. They are obsessed with order and things like that. They need to control their own environment, that basically they want to be in charge. On top of that, the binge type of this condition is associated with substance and alcohol abuse, that over and above the problem with the food, they will also have problems with substances, addictions, and exercise is another thing that they do. Physical exercise to really just try and burn those extra calories to make sure that their bodies do not increase in size. Misuse of medications to control weight, we've mentioned, diuretics, laxatives. Some individuals who are diabetic will even avoid using insulin so that they do not metabolize carbohydrates, and therefore these are not turned into fat and therefore weight gain. This is the epidemiology, a lifetime prevalence of between 0.5 and 3.7. Generally speaking, an onset from early adolescence to late adolescence, early adulthood. with a prevalence of about 0.5 to 1%, and a mortality of between 3 and 8%, which is quite significant. It is extremely rare to find an onset before adolescence, and certainly by the time people are 30, very, very unusual. It can happen, but very unusual. It's predominantly a female disorder with a ratio of 1 to 10 male to female. Studies seem to indicate that the onset may be related to a stressful life event occurring at that particular vulnerable age of between 14 and 18, such as leaving home to go to college or to university. There are also risk and prognostic factors that have been identified. Individuals who develop these conditions seem to have a certain temperament, tend to be, like I mentioned earlier, rather controlling, rather fixed in their outlook, have a lot of anxiety when things don't go their way. They're almost like a type A personality, but not really a type A personality. Then there are also environmental factors like certain cultures that emphasize thinness and being not seen to be fat and avoiding being fat. And if we look at the distribution of these conditions, they are far much more common in newly industrialized countries, post-industrialized countries, and booming economies like happens in the US, Europe, Australia, New Zealand, etc. And then certain occupations also, individuals who are like models, people who are runners, elite runners, ballet dancers, again seem to have a fair share of the condition. The genetics of it are also quite suggestive, with a higher concordancy rate for monozygotic versus dizygotic twins, and then physiological changes that occur with these individuals, as we've mentioned earlier. We have a differential diagnosis for anorexia nervosa, medical illnesses, especially gastrointestinal disorders, where malabsorption may be an issue, hyperthyroidism with increased metabolism, people with malignancies that are consuming, retroviral disease, HIV/AIDS. All these are wasting conditions, so they can be confused for anorexia nervosa. Depressive disorder, major depression disorder, one of the diagnostic criteria is the biological symptom of appetite. Sometimes the appetite is lost, and individuals may lose a large amount of weight, and again could be confused for this condition. People with schizophrenia sometimes have odd food preferences, and therefore may sometimes just prefer to just eat one particular thing that may not necessarily provide for them nutrition, and therefore they end up with weight loss and appear like they could harm the condition. Substance use disorder, alcoholism, use of things, psychostimulants, which are anorexant in many ways. Individuals with substance use disorder may also. And then bulimia, where the person is inducing so much purging, they could end up with features of anorexia. In terms of prognosis, about 40% of people with anorexia nervosa will recover, 30% will improve, and 30% remain chronic as chronic cases. The treatment, it could be outpatient or inpatient. Inpatient depends on the degree of hydration, the degree of starvation, the electrolyte imbalance, and the weight loss. And the aims of the treatment would be to ensure weight gain and to treat whatever metabolic imbalance these individuals may be having. So once you are hospitalizing these individuals, anyone who has a weight below 20% of the expected weight should be recommended for inpatient care, maybe even forced feeding. If you have a weight that is 30% less than expected, definitely a stay in hospital extending 2 to 6 months to just try and correct the nutritional deficiency and the electrolyte imbalances that may exist. And the plan of treatment, usually many patients will resist medication, but we believe antidepressant treatment is very important. The SSRI fluoxetine has proven over time to be very useful. An appetite stimulant like cyproheptadine, also very useful. If the patient is of a good nutritional status, then a tricyclic antidepressant could also be used. And then the main psychological treatments are group therapy, psychoeducation, supportive, inspirational, family therapy, and definitely cognitive behavior therapy. Now, we move to the next one, which is bulimia nervosa. These are the diagnostic criteria for bulimia nervosa. Recurrent episodes of binge eating characterized by eating in a discrete period of time, usually within a period of about 2 hours, an amount of food that is definitely larger than what most people would eat in a similar period of time under similar circumstances. I don't know how many of you go to weddings and you can see somebody loading their plate and loading their plate, maybe because they just like the food. This is more pathological. It's usually followed by other compensatory mechanisms. The person feels they don't have control over their eating, and their compensatory behaviors will kick in, like inducing vomiting, use of laxatives, use of diuretics, fasting, and exercise as a way of trying to just deal with whatever amount of food they've taken in. There'll also be binge eating, inappropriate compensatory behaviors, at least once a week for 3 months. So it's very frequent, every week, at least once the person, and it will go on and on and on, 3 months. Self-evaluation is unduly influenced by body shape and weight, that they have a distorted view of their body shape and weight. And therefore, they think they're binge eaten, they need to do something about it. And the last one is an exclusion criteria, that it does not occur exclusively during episodes of anorexia nervosa. And then there'll be a purging type and non-purging type, and severity is expressed as being either mild, moderate, severe, or extreme, depending on the number of times it's occurring per week over the next 3 months. The lifetime prevalence of bulimia, 1 to 1.5%. Like I said before, in my own clinical experience, I think it occurs a little more frequently than that. The age of onset, 16 to 18 years, again, adolescents, late adolescents, a similar male to female ratio, that it seems to be really a female disorder, and seems to occur in people who have normal weight or people who are obese. Unlike the anorexics who are really below weight, these individuals will actually have normal weight. There are postulated theories as to why it happens. It is said that if a patient is having difficulties with adolescent demands, and if you go back to the tasks of adolescence, there are many, including just relationships with peers, and the demands that are put on these individuals as they try to transit into adulthood to forming stable relationships with opposite sex members and so on. Bulimics are known to be impulsive, angry, may engage in self-destructive sexual relationships. They have emotional ability, and suicides are a risk. It has been said that between anorexia nervosa and bulimia nervosa, the individuals with bulimia are more predisposed to depression and bipolar disorder. Now, the one interesting thing is that this binge eating is ego dystonic, meaning these individuals do not really enjoy eating like that. And so they are the ones who are more likely to seek help. There are environmental and genetic factors that are very, very similar to the anorexia nervosa factors, the socioeconomic states and the genetics mirror those of anorexia nervosa. There are different differential diagnoses that have been postulated. Epileptic fits, CNS tumors sitting in some parts of the brain, the impulsivity of borderline personality. Binge eating has, bulimia and the binging has been likened to the impulsivity that you see in borderline personality disorder. Also, patients with the major depression disorder, as part of the symptom complex, do develop in the atypical symptoms, can have excess appetite, excess eating, comfort eating, and end up similarly. Anorexia nervosa, again, because they do the binge type again, binge eating disorder, which we shall see in a moment, and the Klein-Levin syndrome, that is a neurological disorder that seems to give people very, very enormous appetites. They'll just eat, and they seem to love what they're eating. The only difference is they do not have the other behavioral manifestations of eating disorders. The likely outcome of these individuals is to end up with electrolyte imbalances, hypochloremia, hyponatremia, hypokalemia, metabolic alkalosis, dehydration, erosions in their esophagus due to acidic stomach contents being purged, salivary gland enlargements as a result of the irritation from the acidic contents, dental caries with chipped teeth, moth-eaten, or what look like or have been described as moth-eaten teeth, and so on. It is said that up to 60% will recover within 5 years, but the rest probably will continue to have a lifelong challenge. So again, in treatment, you might want to hospitalize these individuals specifically for these 3 reasons: correct an electrolyte imbalance, correct a metabolic alkalosis, And because these people are prone to suicide or maybe contemplating suicide or have attempted suicide, that could be another reason for them to be admitted. The treatments that have been suggested, you can see, are predominantly antidepressants, both the first generation tricyclic antidepressants, MAO inhibitors even, and the second generation SSRIs, specifically fluoxetine. And then there are psychological treatments, which include motivation, individual psychotherapy, cognitive behavior therapy, and group therapy. The last one that we are going to see very briefly, I know time is running out, is the binge eating disorder. Binge eating disorder is a disorder of a person who will binge eat in a similar period of time as a bulimic person, an amount of food that is definitely larger, very similar to bulimia, a sense of lack of control over eating during the episode, and will have 3 or more of these symptoms. You are eating very fast. You are eating until you feel uncomfortably full. You are eating large amounts of food when not physically hungry. You're not feeling physically hungry. You are eating alone because of feeling embarrassed by how much you are eating. And finally, that the person will feel disgusted, depressed, or very guilty at what they've done. But interestingly, these individuals do not engage in compensatory behaviors that we see with bulimia nervosa. They are distressed, it occurs in a similar period of time, but they do not engage in compensatory behaviors. It's a common among subjects of, attending hospital-affiliated weight control programs. It's rare in the community. Again, more common in females than in males, associated with severity of obesity and a history of marked weight fluctuations. There are associated features, impairment in work and social functioning, over concern with body shape and weight, significant amount of time in adult life on diets, depression, alcohol, drug abuse, and past history of treatment for mood or emotional disorders. So there are differential diagnoses: depression, bulimia nervosa, and borderline personality disorder, for the very same reasons that we've mentioned earlier. So I want to stop there and thank you very much and hand over to the chair.
Thank you very much, Dr. Kigamo, for that very elaborate presentation on eating disorders. I have a question. What about the clean plate principle? We've grown up being told eat and make sure the plate is clean, and in our African setups, when you're served the ugali, it's never small. And you learn to eat really big and ensure the plate is clean. Sometimes when you get served, yes, you're feeling satisfied, but when you remember the principles you were taught, that it's a sin to leave food on the plate, you tend to continue eating. So are these people having eating disorders, or is it just a habit? I've seen you state environment and genetics play a role. So does this have any role anywhere in eating disorders?
Thank you, Dr. Mugambi. I think that in the environments we grew up in, food was not that available. And when you found it, you ate it until you could not, you could not take any more, which was very rare. I mean, if a chicken was cooked in your home, that was a special treat, and you'd be the one eating the feet and the intestines, and eating copious amounts of ugali with that. I think it's really very cultural and environmental in that sense. And I wouldn't call it an eating disorder at all.
Thank you very much. I want to bring in one of our panelists who's a clinical psychologist. I'm sorry, I realized I never added one of our partners within the earlier introduction. CPAK, which is the Clinical Psychologist Association of Kenya, is a key partner within these mental health programs. And today, Yvonne Orlando, who is a clinical psychologist, is amongst our panelists. And we've had clinical psychologists have a big role in terms of ensuring eating disorders are sorted. What modalities are there to ensure that someone with an eating disorder is well taken care of?
Thank you, Dr. Joy. I hope you can hear me.
Yes.
So most of the time when you have patients with eating disorders, we work hand in hand with either psychiatrists or their own doctors because of some of the issues that Dr. Kigamo mentioned. So if there's issues of electrolyte imbalances, the doctors will sort that. On our side, we focus maybe on CBT, like identifying those irrational beliefs. For example, most of them are worried about, I am this particular weight, or I'm fat, or I look like this. We have a form of different pictures of different body sizes that we tell somebody, how do you think you look? So if the person points to a photo that is totally different from how they look, we're able to see there's a body dysmorphia. But most of the time with anorexics, they will know because they keep weighing themselves. They know when they've added a kg. So they'll say the right one, and they mostly want to be thinner. We explore to find out what makes you want to be thinner, what makes you uncomfortable with the way you're looking. Same with the ones who have bulimia. What makes you eat very comfortably in the presence of others, and then you go and purge later on. For the ones who are binging, like right now, especially during COVID, the concern is for anorexics, everyone can see you're not eating. Everyone can see that you have just chopped your food into small pieces and you're moving it around your plate, but you're not eating it. So your family can, they'll call you out on it. And that is distressing for them. So it might lead to more anxiety, more stress, and eventually depression. Therefore, they might also need help for that. So we're also able to work with families. Sometimes just making sure that the family members are one helps in communication to the clients that we are not trying to say you're sick or something is wrong with you, but you're saying there's a problem with the way you're eating. For the binge eaters right now, they're in their comfort zone. If you look on Facebook, people are even commenting, I have added 10 kgs. Ooh, what happens when Corona ends? How will I walk outside? Gyms have been closed. I don't know what to do. So some people are already struggling because you can't purge because everyone is at home with you. You eat even in the toilet because you're trying to hide. We've heard of cases, people smuggling food and you cover yourself at night and you're binging inside your bed so that others cannot see you binging. Then later on, you're trying to purge. But since the family is surrounding you, a lot of anxiety is there also. So we are managing the anxiety. We are working on those irrational beliefs. We are looking at the cognitive distortions. What is this about catastrophizing? If you eat one meal, why do you feel like now you're about to die? All that food has just gone to your hips or to your stomach. We try to address those kind of concerns. We also teach on assertiveness, particularly for the ones with bulimia, because for you to focus on you, not on how others should be viewing you, not on what others are saying about you. When you're more assertive in the way you're looking and feeling, chances are you're able to control what you're eating. For the anorexics, we're also focusing on not focusing completely on the societal perspectives or misconceptions. If you're Kenyan and you want to focus on being Miss Universe, who said that is the most beautiful? Those are some of the areas we look at. And we even look at, there's a Miss Universe 1996. After she won and she was crowned, then later on, she started adding weight. And people were demanding, let's take the crown back. That shows there's a problem. So we raise some of these issues again with the clients, but we work with them. Target being regular eating patterns, controlling food comfortably, and being able to talk about your anxiety. If I'm eating too much now because I'm scared, let's figure out what is making you anxious right now. So they'll be chatting those feelings. And then later on in sessions, we can explore them. For the ones with substance abuse, like heroin, you use heroin, you become very thin. So it might not have been intentional anorexia, but now because of the effects on your body, the person has problems eating normal food. They just want Fanta, sweet things. We also explore some of those things. So it's broad, but we try to individualize it as possible. Oh, we also have an Overeaters Anonymous in Kenya. We had it in Karen. Right now it was moved to Lavington. So if you're having problems with eating too much, they're meeting online. Thank you.
Thank you very much, Yvonne, especially for that Overeaters Anonymous advice. I wish you could share a link where people could connect to that, and we could share it even on our Facebook page so that people do get help. There are people who, yes, are having needs in terms of that. We have a question here for Dr. Kigamoa, and this is coming from Siaya. We have Nurse Leonard Otieno. I have observed number of COVID-19 patients, especially in the isolation unit, eat a lot. Could it be an eating disorder? Well, that goes to Dr. But Dr. I also want to add you one question in terms of the prevalence of these eating disorders in Kenya. You said eating disorders have not been a common thing within the African setup, but do we have a prevalence rate? Do we know how affected we are as Africans within the Kenyan setup?
Thank you, Dr. Mugambi. The first question, I didn't quite get what you asked.
The first question was one of the nurses in Siaya had noted that the COVID patients are eating quite a lot in the wards, but was asking if it's an eating disorder or if it is normal.
I'm not sure that's a shared observation. What I know is that COVID patients who are hospitalized are actually very sick people, and I would be surprised if they were eating more than they should. I think they are more concerned with just their own survival. But nonetheless, there have been observations that the COVID virus is affecting literally all the organs of the body, including the brain. And so some changes in the brain might lead to that sort of behavior. But it's not in my observation, it's not in my experience. Number two, we don't really have studies that can that show the prevalence of eating disorders. What I do know is that Dr. Jenga and a group did a study on elite runners to try and document what kind of lifestyles they were having. I don't remember the figures, but they were not very impressive. They were not the kind of figures we see from the West. The reality is that if you took a survey of psychiatrists in Kenya and asked how many of you have actually met a patient with anorexia nervosa, it will be extremely low. It will be nowhere near what we see from the West. And like I said, my own empirical observation is that probably bulimia actually exists far much more than we see in clinical practice.
Thank you very much, Dr. Any screening tools that one can use, especially in the primary healthcare setup, to be able to identify these eating disorders?
I came across a tool that had 61 questions. I think it was 61. So I don't think it would be appropriate in a primary healthcare setting. I think being able to just use the specific diagnostic, DSM diagnostic criteria as screening could be a good beginning where you suspect an individual may be having an eating disorder. But I'm not sure, maybe Yvonne has an idea. They're the ones who tend to use these screening tools.
I think I'll call upon Rachel Miner. She's also a clinical psychologist. She's amongst us. She'd responded on the other end with some simpler tool. Rachel?
Thank you. Well, yes, the tool that Dr. Kigamo is talking about is quite lengthy, but there is the eating attitude test screening tool, which is a 26-item tool, which is good, can be used in a hospital setting. Though, if the setting is quite busy, like an emergency department, it may not be appropriate. So it would be good to use it probably in other departments within the hospital. So it's a screening tool. Basically shows the severity and informs whether this person needs a referral to either a psychiatrist or a psychologist because of the symptoms they are having. And it's a good tool because based on the answers within the 26 items, it can be a basis to try and find out what the problem is, especially for people who are more interested on the psychosocial standpoint on how this person is doing. Thank you.
Thank you very much. Thanks for the tool also, Rachel Miner. We appreciate and we'll be able to try and use it once you share also a link with us. I see a question from Dr. Kingangi. Thank you very much for being here with us tonight. He asks, this nyamachoma craze with Kenyan males, could it be classified as an eating disorder? Dr. Kigamo.
Sorry, I find that a bit hilarious. I think Nyama Choma has been with us time immemorial. For it to qualify as an eating disorder, it would have to have those characteristics that we are talking about. And either the binge eating disorder, where a person is consuming copious amounts of food in hiding and doesn't want other people to see, or where a person is consuming. I cannot imagine a person eating nyama choma and going to purge. I mean, that would be just the ultimate sin, so to speak. But I don't think it's an eating disorder. I think it's just a craze in our people.
Thank you very much. We have one of our colleagues who has shared that she once weighed 150. It took away her self-esteem. She managed to work it out up to 69 kgs in 6 months. Something that she was told that was dangerous, having worked within 6 months to get to 69 kgs from 150. And then she later developed serious back pain and was sent to theater for laminectomy, but she's back to putting on weight because she cannot do much in terms of exercise. And she's now obsessed with what she eats. She's fasting to try and get back to her normal weight. But she's obsessed with what she eats and is worried about what the family members are telling her. So how would we advise this colleague of ours? How would we assist her? I throw this out to Yvonne Orlando, and then Dr. Kigamo can add a bit on that.
Okay, thank you, Dr. Joy. For the physical impact of it, I think that one I'll allow Dr. Kigamo to address. But for the psychological impact, first of all, to borrow from the presentation of Dr. Kigamo, you realize for bulimia, one of the symptoms is that fasting so that you do not add weight. And she's mentioned that's one of it. I think a proper assessment would be needed for us to understand this need to really lose so much weight. We could focus on ways to be able to maintain her current weight in a healthier way than the fasting. My recommendation for now is I think she can reach out to me. I can offer free therapy for her, and we just work on that from the psychological angle. But for the health effects, I've had it, I've had other patients having such kind of experiences, but allow me to let the medical doctor respond to that part. Thank you.
Sorry, I didn't quite get the question around the medical. I mean, she was overweight. She went and had to have laminectomy, and now is eating very carefully to control her weight.
She's also fasting.
Yeah, we are all doing intermittent fasting from time to time. Yeah. But what kind of fasting are we talking about?
She's not put down what kind of fasting.
Yeah, because I think that if a person is determined enough to lose weight, and the equation has always been how many calories you take in and how you can maintain those below a certain minimum, so that whatever you save on the calories can then come out of your body fat and so on. So fasting is part of the strategy for losing weight. But the kind of fasting we are talking about in anorexia nervosa is pathological. And it is based on irrational evaluation of the individual's body size and image, which is a pathological thing. I am not sure this colleague of ours is going through something like that.
Thank you very much,
Joy,
Dr. Yes.
If I may add, we also need to remember that for most people with eating disorders, they have to work hand in hand with a nutritionist. So I think for her also a nutritionist would come in very handy to help her feel better and also not add the weight.
Thank you very much, Yvonne. I have requested her to get in touch and we will link her with you. We've got someone, Alfred Oginga, who has asked, Doc, I think my two kids, 8 years old and 3-year-old girl, seem to have this rumination thing. It sucks at times when they just decide to throw up after feeding. How can I be helped?
So with rumination disorder, the individual basically is regurgitating the food either in response to some emotional problem or because they have a problem with their digestive system. But from a psychological, psychiatric perspective, we believe that evaluation for a possible emotional problem would be the way to go.
Thank you very much, Dr. There's lots of questions in terms of the eating disorders in children. And I don't know if this is adequate time to tackle the eating disorders in children, or do we bring you back for another session for children? Because many people are asking, their children are very picky, others are not eating at all. Are these disorders, or it's just a stage in life?
Yeah, I think, well, I'm not a child psychiatrist, but the reality is that our parenting model has tended to promote eating in our children, almost force feeding. And these are behaviors that then get carried on to adulthood, and we end up with children who are very obese and things like that. And then there's the opposite, where the children have preferences for certain types of foods and prefer not to eat certain types of food. Traditionally, you know, vegetables are not very welcome in children's diets. They don't like them. They don't enjoy them. They look at them and say, yuck, I don't like that. So anyway, I am for us having another session, but I think you'll need to bring on a child psychiatrist as well.
We will do that. Thank you so much, Dr. Kigamwa. There is lots of questions, but we will stop there due to time, and appreciate the fact that you took time. You've really enlightened us in terms of eating disorders. We will now hand this over to our mental health chair, the one who chairs our committee within KMA, Dr. Somba, to give us a closing remark. Then we'll share with you a bit of the activities that we do within KMA. And then Dr. Liz Ahemba, who's the chair of CPAK, will share about what's ongoing at the call center. There has been a lot of questions in terms of the activities at the call center. We know there has been some hitches here and there, but these are being rectified. There is always hitches when something is being piloted, and we do apologize, but we have learned a lot from your feedback, and Liz will share more about what's happening at the call center and the call numbers that you can use in the meantime. So I welcome Dr. Somba to give us his remarks.
Thank you very much, Dr. Mugambi. Good evening, everyone. Can you hear me?
Yes, Dr. Somba.
Yes, yeah. Thank you very much, everyone. And so thank you, Dr. Kigama. You have dealt that topic very well. I'm sure we'll call you back to give us more talk about disorders in feeding, especially the picker. People like eating other things that are not food. I'm sure there's a lot that we need to know. I also like to thank Yvonne for being there, Lano, and everyone else who has been there, actually. I think this is a very important session. We are together, although we are far, but I think this brings us together. So let us stay safe. Let us avoid what you have been told about. I mean, I'm sure it is purely medical, but if you see a case that has problems, the anorexia nervosa, which is not really African, well, in quotes, condition, I think we are people that we can refer those patients to. So, Joe Mugambi, thank you very much. You are the face of webinar in KMA, and everyone else, thank you so much, and have a good night. Thank you.
Thank you, Dr. Somba. I will put up part of the activities that we are doing before Lisa Hemba comes in and shares more on what we are doing at the call center. So we have learning activities that are ongoing within the KMA and also the partnership with our partner associations. We have the Picha Kucha division nights, which were on a break, but we are resuming this week. We have had the mental health webinars. We said this is the 14th mental health webinar. We've learned a lot. I think I'm becoming a mini psychiatrist, but it has really helped. I run a COVID center, and part of what I've learned from the time when we began has really helped in terms of psychological first aid, counseling of the clients who come in. And when we attend these webinars, we get to learn what others are doing. Where I am is really far, and we do not have a psychiatrist to be able to assist us with the care. But as primary healthcare providers, we are able to provide what we can. So we are having Thursday COVID-19 case management webinars. We had the home-based care COVID-19 protocol webinar as the first. Then we did the outpatient triage patient flow management during the pandemic. We did another one on IPC, which was hosted by KCOA. Then we had one last week on lab and testing strategies, but we have been asked to run another one. It's on high demand in terms of lab and testing. So we'll be doing a COVID-19 testing strategy. The speaker will be Francis Hugo, who's a clinical pathologist, at Nairobi Hospital. And with the following panel, our moderator will be Dr. Felicitas Bosibori, who's a member of KMA from Kisii, and she'll be moderating this session from Kisii Teaching and Referral Hospital. So we look forward to having you attend this session. They are usually held at 2 p.m. on Thursdays. Please diarize and be there. Then these are the Picha Kucha sessions where we have gone through these 7 divisions, and we hope that other divisions can come along and be able to also share with us what they have done. We are now moving to where we are at in terms of management of COVID post opening of Nairobi and the regions which were the epicenter. Where are we at in terms of divisions, and what are we doing right now? So we have the call center, and Dr. Lisa Hemba will share more about the call center, where we are at currently. We've had our hitches here and there. Calls have been breaking once in a while, but our partner, who's Kansas City, is working on that. Wherever we are having challenges, we have alternative call numbers. Though they are not toll-free, you can call on them. Dr. Lisa Hemba, I welcome you to share more about the call center.
Thank you very much, Joy. Yes, the call center is up and running. As Dr. Joy has said, we really have had some hitches here and there. We've had hitches with calls, we've had hitches with the numbers sometimes. And we are still going strong despite that. So we really do hope that you will call us. The call center is run by a team of mental health specialists who are part of this partnership that have organized, these webinars. That's Kenya Medical Association, Clinical Psychologists Association of Kenya, Nursing Association, and KCOA, the Clinical Officers Association. So we are still running, we are still going strong. We have our toll-free number, which is on the screen, the 0800-720-608. And then we added other numbers, which you can call, as this is the only toll-free number we have for now, but the other numbers are not toll-free, but you can call them, and we will, when the calls drop, we will try as much as possible to call you back so that we are able to have a conversation. So please feel free to call. We are here for you. We are healthcare workers just like you, and we realize that we really do need to take care of our own. Back to you, Joy.
Thank you very much, Liz. We thank everyone who has logged in tonight. It's been a fantastic night. We have learned about how to manage eating disorders. Wherever you are, rural, urban, peri-urban, ensure that you can be able to detect them, you can be able to manage them and refer them appropriately. We appreciate each and every one of you, our panelists, our speaker, and our attendee for being here tonight. Your CPD points will be sent on your email if you're under KMPDC, and the nurses code will be sent on your emails tomorrow morning with the thank you email that comes after the webinar. We'll also add on it the extra numbers that you can call for the call center. And then for KCOA, we will share the list with your association, and they will be able to disperse your CPD points based on attendance. And we said at least be online for 30 minutes so that we can as well give you your CPDs. That means you'll have attended at least 3/4 of this or half of the session. Thank you very much. Have a good night and stay safe. Remember to use your personal protective equipment. Remember to wash your hands. Remember to ensure that you have personal distance. And join us on Thursday and Friday for our other webinars. Thank you very much. Have a good night.
Good night. Bye.
Thank you and good night.
Good night.
Good night.
Bye.